Good morning, everyone. Thank you for joining us, and I hope that you are all safe, healthy, and doing well in your respective parts of the world. My name is Daanika Kamal, and I will be moderating this session today to look at how we can prioritize the mental health of women in the workforce during emergencies. COVID-19 has taken an unprecedented toll on women, especially those working on the front lines of the pandemic. While grappling with a number of different impacts of this global emergency, they've also had to face harassment and discrimination, including aggression and violence towards female medical personnel and health workers, which has deepened the mental health crisis in South Asia and worldwide. What we hope to do during this session is to identify the unique mental health needs of women in the health workforce during emergencies and explore why it is essential to integrate mental health into the COVID-19 response moving forward. We would also like to see how women are leading this change, particularly in South Asia. With us, we have Gracy Andrew, Vice President and Country Director India at CorStone. We have Dr. Prabha Chandra, Professor of Psychiatry at the National Institute of Mental Health and Neurosciences in Bangalore, India. And we have Dr. Fatimat Nazla Rafeeg, Head of Communicable Disease Control Health Protection Agency in the Maldives. Prabha, I'd actually like to begin this session with you. A recent study conducted by CARE, a nonprofit aid organization, found that women around the world are almost 3 times as likely as men to report suffering from significant mental health consequences due to COVID-19. What do you think are the specific factors or experiences that make women healthcare workers more vulnerable to stress or trauma during emergencies?
Thank you, Daanika. It's lovely to be here on this panel. And I think that's a great question because I would say that there are probably 3 things which are causing a lot of stress and mental health issues for women. The first one would be stigma. I think frontline health workers who are women face a lot of stigma from their family, from neighbors, as well as there's a lot of self-stigmatization. So there's a sense that in some way they are infected. So they tend to feel that they are infecting others. They may cause trouble to their family. So I think that's the first thing, the whole area of stigma and feeling that they might infect somebody. The second, I think, would be isolation. Women thrive on partnerships, on collaboration, on being with others and networking. And I think the lockdown and quarantine issues have really caused a certain constriction of their network. And everybody does not have smartphones or internet access to be able to communicate very easily. So the sense of isolation and not being able to be with their own families and friends is the second thing. And I think the third is just watching all the death and the despair and depression in patients, which is causing a lot of stress as well. Because particularly nurses, I find whomever I talk to are finding it as a struggle to be with patients who are suffering. And every day there is a loss of a patient and they feel that they cannot manage them. So I think those are the 3 things: the sense of being stigmatized because of the infection, a sense of being infective, the isolation, as well as the losses, the multiple losses. And I'd like to talk about it a little more later on in the session. Thank you.
Thank you. Thank you very much. Gracy, I'd actually want to ask you a follow-up to that. We spoke a little bit about stigma. So through your work and your experience, are there any particular examples you can think of ways that women healthcare workers can create support structures for one another, especially for those who find it challenging to ask for help given the stigma surrounding mental health issues? Sorry, Gracy, you need to unmute. Thank you.
Yeah. So our work has not started with health workers. Our work has mostly been in schools with teachers, but we are about to start some work with health workers, in the future. But what I think is our work is around resilience, building resilience skills among teachers, and we plan to build resilience skills among health workers, because I think that is resilience. Actually, when we talk about resilience, a lot of people, it's become the buzzword nowadays. You keep hearing resilience everywhere. But when I'm talking about resilience, I talk about emotional resilience, a set of skills that help people to cope. And what I find is that there's a lot of research that has gone into this area of work. And what has been found, and especially in epidemics or in these situations, on disasters, researchers found that when people have self-efficacy and social supports, they are able to cope. And that most people don't have PTSD or depression. A large number of people actually cope. Everybody suffers in the aftermath, but after some time they learn to cope. And the two very important skills, one is self-efficacy and one is seeking such social supports. So in our work with teachers and in schools, what we found is that teachers have been able to use these skills during this pandemic. Every student and teacher that we've talked to has been able to, whatever we've taught them during the program, they have been actually been able to draw from these skills that they have learned by seeking support. So you have to learn how to and where to seek support, social support, and how to kind of build that. And that is what helps people, and that's what I think is important for us to integrate within whatever training or program that we have for health workers, because that's the way we could build their resilience and build their skills and build their abilities.
Thank you. I'm going to come back to that just a little later, because I think that your work, especially around emotional preparedness, is very, very interesting. But I'd like to now go to Nazla. And I want to ask, so quite early on in the pandemic, the Maldives had announced the establishment of a mental and psychological support cluster to increase awareness and advocate for mental well-being. Are there any specific steps that your country has taken for mental health during the pandemic that you feel have been particularly impactful? Sorry, Nazla, you need to unmute.
I'm sorry. Yes, very early on when our National Emergency Operations Center was established, it was felt that psychosocial support and mental health mental well-being would be an integral part of this emergency response. It is actually included in our health emergency response plans, that whenever we respond to any health emergency, mental health and psychosocial support would be one of the key areas that we respond to, in addition to, doing contact tracing or vaccination or the other technical disease-specific actions that we do. So what first started as just a number, a small cell that would call people who are in quarantine and in isolation, because in the beginning we had very few people, very few cases and few contacts, and they were all taken to isolation or quarantine facilities away from their homes. So it was very important for us to be able to talk to them. This was a very new experience for people being in quarantine, being in isolation. So we were able to respond to their needs, and also this was one way which we were able to identify issues in our response that we needed to correct very quickly, and we were able to do that because that contact was there. And then we were able to scale up this response to form of full-fledged psychosocial support and mental health cluster, which had different functions. Many partners, over 30 partners came together, government agencies, UN agencies, NGOs, the Maldivian Red Crescent was leading this. But a very good partnership actually came through this response. And they had two areas of work. One, helping within the community. They established a hotline that people could call for their needs, to attend to their needs. They also established referral systems. So people whom they identified through the hotline, if they needed additional specialist mental health care, they were referred to, or whether they needed any social protection, those systems were set up. Also, they did a resource mapping exercise to see where additional resources were needed. Maldives being a very small country and also not having in recent history experienced such a large emergency, it took some time to set up these things, but after we did that, we found out that this was quite impactful. It has brought mental health actually to the forefront, which usually remains very hidden. People are more open to talking about it. And also, I talked to some of my colleagues in the PSS cluster, and this one phrase they said really stuck out to me. They said, now we feel like we have a seat at the table. So mental health gets taken into consideration when decisions about the response is made. So that's quite an achievement, I think, for us.
That is, thank you so much for sharing that. And I think there are a lot of lessons that we can take and implement in different countries as well from the Maldives. You know, we've spoken a little bit about it, but women worldwide have faced additional challenges during COVID-19. You know, I mean, you have challenges that come with the pandemic, but then also increased job insecurity and additional unpaid care duties. And Prabha, I'd like to talk to you about this as well, because Dr. Nazla also briefly spoke about this, about how the societal challenges play a role in mental health as well. And one of your your most recent research papers actually examines COVID-19 related psychosis into women and how it is closely linked to sociocultural issues and vulnerability. Could you tell us a little bit more about how you see the mental health of women, both healthcare workers and otherwise, interlinked with sociocultural issues and norms?
Yeah, I mean, I'd like to talk about both of those issues, sociocultural issues and vulnerability, because I think in some ways they are interlinked. I think in terms of sociocultural issues, women, conventionally are caregivers in our society. They are the ones who hold the family together. And a lot of the health workers are finding it extremely challenging to manage all of that, particularly without any childcare. So a lot of elderly are not with the family members. So conventionally, a nurse or a doctor would leave her kids with her parents so that they can be looked after. And now, because they don't want to go to elderly parents' place and cause trouble to them, they don't have anybody to manage them. So there's a lot of, or they leave them far away and sort of work in the hospitals and don't see the children for weeks or months on end. I think that's causing a lot of distress to women. The second issue is one of domestic violence, and I think that's something that we really need to talk about. The whole area of violence actually increasing, even among health workers. All kinds of violence, societal violence, but particularly domestic violence, because like I have people who are working with me, health assistants whose husbands were taxi drivers and they've lost their jobs. So they are at home, these women come out to work. There's a sense in the husbands of not being in control any longer. There's alcohol use. And as a result, there is psychological and sometimes often physical violence. And yet these women have to face all of that and come daily to work because they are the only caregivers and the only earning members for the family. So I think these are the kind of challenges. So suddenly women's roles, particularly women health workers' roles, have changed in so many different ways. In terms of vulnerability, any woman who's gone through trauma earlier of any kind, it may be sexual abuse, it may be other kinds of separation trauma. I find that COVID has brought a resurgence of that whole trauma element, and many women are coming back with PTSD kind of symptoms. And these are not just anybody. These are doctors, nurses, otherwise very strong women who are having a resurfacing of trauma because of the whole, the lockdown was terrible for a lot of doctors because many of them were staying in hostels or in the hospitals away from family, thinking that they may not see their families again because there was such a lot of fear of death. And the resurgence of trauma related to women who are otherwise vulnerable. A lot of my therapy patients were actually those women who had a resurgence of trauma during this time. And that is known in times of crisis, in times of disasters. You can have earlier trauma which gets triggered off by so many events. So I think the sociocultural issues are also about, women in South Asia like their festivals, they like their celebrations. That is the time they get to be with other women. And now we've not had a single celebration or a festival since March. And particularly in India, and I know in many other countries in South Asia, we thrive on these family-related celebrations and rituals. And not having that has actually, caused a lot of sociocultural vulnerability. So I would think that there are these many hues by which women have been affected quite seriously.
Thank you. Gracie, if you could add a little bit to that, because we were talking about these sort of sociocultural issues and, resurgence of trauma, especially in times of emergencies. I'd like to go back to what you mentioned about resilience and emotional preparedness, because I think that that idea of emotional preparedness is something that can very much be relevant in situations like this. So how exactly do you see emotional preparedness, and how is that something that we can sort of work into our responses for emergencies? Sorry, Gracie, mute. Thank you.
In the beginning of this conference, right from when Barka spoke and even now Prabha was talking about, is the amount of difficulties that health workers face. It's unimaginable in terms of the challenges that they face. But if you look at what we have done in terms of any training that we do for health workers, the focus has always been on what is the service they have to provide. How can they best provide those services? Very, very little focus has been, or at almost still, on about their well-being. How do they develop their own well-being? How do they focus on burnout? What do they do with, when they have to face this? And I go back to our work with the schools again, because that's experience in teachers. The way we did that was that when we started training teachers and we asked them to work until and unless we started focusing on the teacher's resilience. So we developed their skills to build their own resilience, to cope with their own stress, and then they were able to engage with the program. In the same way,
could you give us an example of a kind of activity that you did or a tool that was provided to sort of help build that resilience?
The program that we have comes a lot from the area of social emotional learning and positive psychology. And we focus a lot on helping teachers recognize their strengths. So this whole area of recognizing what your strengths are, how can you use them? Simple skills like gratitude, and looking at just simple empathy. How do you show empathy? How do you listen to people? This is not rocket science. Very, very simple skills that we teach them. But when we teach them and they're able to apply it to their own lives, they find that their lives change and they get engaged with the program. And today, when the pandemic happened, time and again, every teacher and student that we talk to would tell us that I could use those skills to help me deal with stress. So I think that and the other thing that I would like to say is that when we train the teachers, but we also touched the system. We touched the block level officers, we touched the district level officers. So that's the way to go about it, is to integrate resilience training within existing training programs that are there for health workers down the line, so that you have it touching the system and you have these health workers being able to use those skills, and be prepared.
Thank you. Thank you very much for that. Actually, so I want to talk a little bit about, how, because you mentioned this, the skills that you provided these teachers was essentially to elevate them. And I think that, trying to elevate women in public spaces is very important. And I think that, Nazla is one of those two women who has been doing that. She's someone who's been very active in her country's COVID-19 response. And as a spokesperson, you even continued your briefings in Nazla, when you were in quarantine, when a family member of yours had tested positive. And, we keep sort of talking about how women are facing multiple demands and challenges, but we rarely get to see, public examples of what that looks like for women. And because you're sort of in that position, Nazla, I'd like to ask you, how can we elevate the experiences of women on the front lines right now? And not just in the health field, but otherwise as well. What kind of steps can we take to elevate those women?
Thank you. Yes, I had to go into quarantine, and it was a very considered decision of our team that I should continue my briefings from home as well. It was important for us to show that anyone could be affected by the pandemic. I think when we talk about frontliners, frontline workers, in the pandemic, usually we focus on people who are working in the health facilities. Of course, they are at the front lines, but there are also those people who are working behind the scenes, doing contact tracing, attending to the hotlines, doing all the administrative logistic work, all the rapid response teams. It's not just the people in PPE, but those people who sit behind desks usually. But they're also frontliners, and they also actually bear the brunt of people's frustrations with the restrictions, with the economic and social impacts that is coming on. So it was important for us to show that we, those who are working on the response, not only are working on controlling it, but we ourselves are also getting impacted by it. So that was one reason we wanted to show that, okay, I'm in quarantine and still like working from home. And we also wanted to show solidarity with those who are working, those who are stuck working at home during the lockdown. And of course, in communications, the continuity was also very important. What people didn't see was behind the scenes when I was prepping for the press briefing. Sometimes my toddler would be sitting on my lap and helping me with my work. I think what happens is we always adopt our professional veneer when we go out in public and we talk about work, about the response, but rarely we talk about the toll it takes on us and what actually it takes for us to be able to do this job and what's the effect it is having on. As spokesperson, sometimes some media also ask me for interviews, and sometimes they want to talk about personal issues, how I'm handling having a family and doing this work. And then my instinct is always, no, let's talk about work, not personal things. But when I was thinking about this, I think this is actually an opportunity for us to change this and for us to talk more about, show actually what is happening behind the scenes. I know some colleagues who've had issues with their relationship because they've been working for so long. I know some of our staff, one of our staff right at the moment is at the hospital because her mother is in critical condition after having COVID, but she's been here at work day and night. So even through this, the work continues and we have to do our job. So I think one way is that we can show the humanity and the human side of things, who we are as people. I'm a mother of 2 children. There are people here with children with some severe disabilities, but because of their role in the Ministry of Health, they are working here and have to continue their work. One thing our communications team has decided right now is also showing the people who are working and show a more human side to them, see their frustrations, their difficulties. Today I got to learn that one staff who was working in the call center, usually during their day, during their shift, they have to listen to a lot of abuse from some people. People are understandably frustrated, so when they don't immediately get what they want, they will take it out on whoever they are talking to. But unfortunately, this staff was also experiencing some difficulties at home and coming to work and listening to this. So this has been quite difficult for some people. We started having, we at the mental health cluster here started having some support groups for the workers here also at the emergency center because of these issues. So I think in order to elevate and the experiences of women and to bring this to the fore, it is very important for us to be first willing to talk about it and acknowledge that some of us are having a hard time, and somehow in a way to show that. So our communications team is working on some documentaries about the response here, and we decided to include some human stories of some of our key workers as well. We want to document the response for posterity, but we also want to acknowledge that this is taking a lot from the people here. This has now gone on for a long time, 7-8 months. Some of us unfortunately started this year with a measles outbreak, so we've been in emergency mode for 10 months now. Usually emergencies, we can work in emergency mode for a long time, I mean long hours for a short while, but when it's extended, then it really becomes an issue. Yeah, so we need to start being more open to acknowledge what we are going through, and then be able to be willing to share it, I think, with the public, with the media, and with the policymakers as well.
Thank you. Thank you very much, Dr. Nazla. I think it is very important for all of us to start sort of sharing our own experiences. And, you know, when you were talking a little bit, especially about working women, I think there's hasn't been much talk about the toll that COVID-19 has had on them, because their, you know, working hours have obviously increased. You know, working from home means that they're juggling both their professional commitments and also their commitments at home within the family. And Dr. Prabha, I wonder, you know, if through your work, if you have any sort of guidance for partners and families of women on how best that the women can be supported during this sort of a period where, you know, the lines between professional and family are sort of blended and everything is happening within the confines of the home.
Yeah, so very early on, we sort of decided that we're going to develop these little leaflets and, you know, guidance notes for women and for partners. My work centers a lot around maternal mental health and women with young children. And so one of the things that we did was develop a very interesting guidance note for obstetricians. To sort of take care of their pregnant women and postpartum women, and also talk to partners about it. Because we had a lot of health workers who were also pregnant, and this was a group which is, even till now, there is not enough data, and we are right now doing a qualitative kind of a study on what is the experience of a pregnant woman coming into hospital, working, and feeling so vulnerable, yet wanting to give back. And many of them have had to have COVID tests again and again, you know, even with the sense of vulnerability. Though there are rules that you need not come after a certain stage of pregnancy, but they're all trying to save their lives. So, you know, it's also about the systemic and the way the management of places allows leave in situations like this where women are more vulnerable. So what I've been doing is talking to a lot of companies and you know, workplaces to try and be more empathic to women working from home, to understand that there is no childcare. So there's a lot of difference when women come into work when the children are away. You know, like Nazla was saying, the toddler was on her lap and she was trying to do something. So just to give a sense of, you know, that reality to bosses and to employers, including within hospitals and at your own workplace. Sometimes it's very easy to preach to somebody else, but to actually show it as an example and say that this is what we're doing. So for example, many hospitals we approached and we said we want to talk to the women workers, and they said, we don't have any time. Everybody's on very difficult rotas, and people are on quarantine and isolation, so we can't give you the time. So what we said was, okay, we'll do a lunchbox meeting. So let's talk to them during their lunch breaks. So all of them have lunch breaks. So we are not taking away any time. So let's talk to you on your lunch break. So they would bring their lunch box. We would have a lunch box here, and we would talk to different health workers in different hospitals and try to make them use some of the methods that Gracy mentioned. Also, I think a lot of health workers wanted to be heard. And they felt that they really had no opportunity. All they were doing was coming, working, seeing a lot of distress in people, and then going home and trying to manage their lives there, which were equally difficult. So I think just getting a little lunchtime to kind of talk about their issues, feeling validated, and more than anything, feeling valued. So, encouraging employers to kind of say, you were the worker of this week, or, you did a great job, or sending out a note that this person did so well. I mean, all of these things actually added to their sense of worth and made them feel that some of it is worthwhile and it's being recognized. The other thing that we did was something called Schwartz rounds for nurses and particularly for residents. Because the trainees were really frontline, because it was easier for, like Nazla said, some of us are at the back and some of us are in the front. So, so the Schwartz rounds are basically more reflective rounds. They are not patient-related medical rounds, but how did you feel when this woman with a young baby came in and that woman was gasping? How did you feel when the elderly person who kind of reminded you of your grandfather, came in, and what did that do to you? So I think, how did you feel when you had to take away resources from one person, and give it to another? What was going on? And then the group kind of reflected on some of this and talked about it. So I think these are some methods that we have been using, both with and encouraging employers also to develop these methods on their own. Not depend on somebody else, but kind of develop it in-house. So I think just getting it all, started, the dialogue going and the conversation going around some of this has been itself a challenge, but I think we've made a beginning somewhere.
Thank you very much. I think that's very enlightening with the different sort of ways. And when I want to come back to a point that you mentioned about wanting to be heard. And I think that, for example, for me, I've noticed that social media has become a tool that, healthcare workers have used quite a bit to share their insights and share their experiences. And it's been very good, but it also has obviously a negative context to it, because social media can be used for abuse and to, sort of oppose or try to prevent the work that's being done by healthcare workers. And I was just wondering, if there are any specific steps that we should be taking to support, women and healthcare and female healthcare workers outside of their traditional work environments, which is why I was sort of, asking about the different ways that we have looked at the different kind of organizations and what they're doing. And Gracy, I'd like to ask you, because you come from a different organization and I think quite a large organization as well. Is there anything that you would like to share with us about how how the organization has sort of assisted women during this time, with work from home arrangements, and whether it requires flexibility or otherwise, or if there's any lessons that you have brought forward that you could share with us?
Yeah, so as an organization, we have worked with our own staff on, how do you deal with the stress of the pandemic, of working from home. We've introduced a lot of support groups, where small support groups among the staff, to be able to share what they're facing and to be able to find strengths and use the skills and share the skills that they use to cope. We've worked with teachers. We've kind of talked to teachers and had one-to-one talks with teachers on how they could work within this atmosphere, this having to work from home, manage children, and manage their work. Of course, schools were closed, but teachers now have to do some online teaching. So how do they deal with that? So we have been doing some work with that. And some of what Prabha says resonates with what I've been thinking about, even the health workers. When they speak about their problems, they hesitate to talk about it in front of supervisors. So it's important, like Prabha said, to train supervisors and employers in letting women have that space to share. So it's not that you get somebody from the outside, but you really create an enabling environment within the system. So in the same way in schools, we try to create an enabling environment within the schools. We talk to officers about how can you listen. So bringing in empathy within our work environments is very important. And I think that's the way forward.
Thank you. Just doing a quick time check. We have another few minutes before we get to the Q&A session with the audience. And I wanted to talk a little bit about women leaders. We now have academic data to support the claim that COVID-19 outcomes have been better in female-led countries. And while these differences aren't necessarily innate, there has been some research to show that women do tend to lead with more empathy at times and greater ability to connect with people. And for an issue like mental health, which is all too stigmatized and very much continues to be in the shadows, Prabha, I'd like to ask you first, and then I'd like to also go to Dr. Nazla for this, for a different perspective. But how can women leaders play a part in streamlining mental health considerations into an emergency response?
I think the success that women leaders have, one is because, they are very collaborative in nature. They do not work in silos. And we know that mental health is something that is, cuts across, it's intersectionality. It's basically cutting across all areas. It's about violence, it's about poverty, it's about patriarchy, it's about the economy, about availability of medicines. It's about a whole range of things. So I think instead of taking a very biomedical, narrow kind of an approach, I think the advantage that women have is that they tend to be, they're trained to be collaborative. You can't run a family without being collaborative. So I think because of that, you tend to take in partners and you're not worried about the competition. You're not worried about power. So you basically work in an egalitarian way, in a way that everybody gets credit and everybody gets, honored, and you look for solutions, because that's how women function, that you look for solutions. And I think that is one major thing. Second is, I think women are used to dealing with crisis quite often in their lives. Things keep happening and you think on your feet and you try not to get submerged into it. And again, very solution focused. So I think these are the two areas. And then all of this happens under the umbrella of caring and, being empathic, like Gracie mentioned. So I think because of that, women leaders are able to do much better in a situation like this, where it doesn't become about yourself, it becomes about a larger purpose. And I think that is something that women are able to, to do so well. And I think, like you mentioned, there is enough evidence that that is happening. And I've seen that happening, like a lot of my trainees, nurses, they all really appreciate the fact that they felt more heard, including male trainees, feel more heard by women leaders. And in fact, are very happy that at this point of time, my department is headed by a woman. So they're really excited. They're very happy that a lot of the senior people are women and can sort of understand what is going on. So I think it's just this power that we have within us, which is not about power or being the one person who will do things, but to take everybody along. And I think that's the one quality why women leaders are doing really well.
Thank you. Dr. Nazla, is there anything you'd like to add to that?
Thank you. I quite agree with what Prabha has said, and I think one additional thing is, as Daanika, you mentioned in the beginning, some research also shows that women have gone through these things at a much higher rate than men. So and also women leaders where they are right now, on the way there, they would have experienced all the difficulties and issues that come with it. So when we have women leaders, that means we have people in a position where they're able to more empathize more with the situation other people are facing. Either they have been there before, or they know somebody who's been there before. Women tend to be, I think, better listeners, and people who share, other people tend to share things with women more, I think. So they tend to come from a place where they are more understanding of the situations and issues and difficulties people face. So the empathy that gives them, the understanding that gives them while they are in that position, I think it opens opportunities for them to help. They are more willing to make things easier for others and to look into ways that can help others. So I think that is one difference that women leaders can make.
Thank you. And just before we go into the question answer, we have quite a few questions coming in from the audience. So I just, Gracie, is there anything that you would like to add to the question about women leaders and how they've sort of interacted with COVID-19?
Actually, I completely agree with Prabha and Nazla, and I don't have anything to add to that. But I really want to say one thing about around something that Prabha mentioned, but I really would like to make a point about stigma around mental health. And I just feel that it's time for us to change the narrative around mental health, that mental health is something that we all, it's a part of everybody's life. And though, it's not that people don't have depression and disorders and dysfunction, but mental health touches all of us. And if we try to kind of bring the well-being perspective in, we may be able to kind of deal with and broaden this perspective of mental health. Probably we'll be able to deal with the stigma around mental health. That's a point I just felt I wanted to bring in this conversation.
Thank you. Thank you all very much. If it's okay with everyone now, can we get into the some of the questions that have come in from the audience? So we have a question from Sharanya, who asked, is there any data or research to show that emergencies affect the mental health of women differently than men? And how and what ways does gender affect how well a person is able to cope? I think we did answer this quite briefly, but is there anything, Prabha, perhaps that you would want to add to this?
Yeah, I think it's been quite clearly shown that disasters and conflict situations, cause more difficulties to mental health problems to women than to men. Men tend to react slightly differently. Substance use, violence, all of that is the way that men react to some of these difficulties, whereas for women, it's more depression and a lot of PTSD. So definitely there is a gender difference. And like I said, a lot of it is related to probably prior vulnerability and also the ongoing trauma that they face because of many of these. Everything gets kind of, the systems which protect women completely go away. So if you look at the kind of child marriages which are happening or domestic violence which is happening, so all of this actually adds on. So it may not be the disaster itself or the pandemic itself or the crisis itself in that sense, but all the attendant things that happen along with it actually add to the stress and increase the rates of mental health problems.
Thank you. We have a question from Miriam, who says that initially employers were supportive, but the trends seem to have now changed. And she's asking, is empathy dwindling with women now being asked to move to part-time contracts or find help at home? Gracie, perhaps you could answer this. I think she's she's talking about how there's been a shift in the way that, the support systems have worked in organizations, where initially there seemed to be a lot more support and flexibility given to women. But now as the months go on, the expectation has sort of has changed a little bit. Is that something that you could address?
Yeah, I think the way I see it is that we have to advocate for the change needs with employers, and women have to, I believe that women can advocate collectively for their needs. And we need to kind of talk to employers or advocate for the needs of employees, especially women employees, uh, because it's even otherwise in work situations, in many work situations, we do not consider the needs of women. A lot of organizations do not consider the needs of women. And now with the pandemic, it's got worse. The difficulties that women face is not considered, and I think it is important to drive policy by collectively working towards talking to the government, talking to employers, writing about it, advocating for change, because that's the only way we can bring change. Collectively advocate for our needs.
Thank you. Is there, Dr. Nazla, would you actually like to add to that? Given your position, especially with the government, is that something that is there a change that you've seen as time sort of goes on in the flexibility and the support that is being provided to working women?
In some parts, especially in the private sector, yes, I think when we initially had a lockdown that lasted about 2.5 months, and when the fear of the pandemic was quite high, we did find that even a lot of private employers especially did allow people to work from home, because at the time there was very little choice. But then as more reopening took place, we did have a lot of national guidelines around how officers should be working. We were still encouraging working from home as much as possible, shortened working hours at offices, and to have shifts, if possible, to decrease the number of people physically at one place at one time. With the pandemic, of course, transport is also affected, with the buses and ferries operating at lower capacity. So I do think, yes, some sectors, especially in the private sector, less so in the government sector, have there's this idea that COVID is gone, or the danger is past us, and then we have to move on and go back to what was normal. So there's a push to go back to working arrangements that were there before. But the difficulty with that is schools are not fully yet open, so children are still at home, children are still going online for their classes at different times than usual. Childcare is very much limited. So there is people are really facing that difficulty of having to adjust to the new normal, as well as trying to be as productive as they were before the pandemic hit.
Thank you. We just have time for one more question. This is a question from Judith. I think, Prabha, you might be best suited to take this one. Judith is asking, are children also affected by the abuse? And if you've sort of seen this, especially in the COVID-19 context. And she's also asking, what role can social media play to help women, or rather does it end up having a detrimental effect? So I think through your work, you might have interacted quite a bit with women who have also tried to find support through social media, and B, those who have been more negatively affected by the impacts of social media. So I think leave those for you. And the first question was regarding child abuse.
Yeah, I think one of the things that we were all very worried about was that many perpetrators are usually people who are very close to the children, and that is something that particularly in India we found that a lot of kids were actually calling the helplines. So in India we had a psychosocial helpline which started quite early in March. And soon we realized that a lot of the callers were kids. So then they made like a, 1, 2, 3, 4. So they had 1 for like general things, 2 for a child, 3 for a woman, and 4 for elderly. So, and we realized that the number 2 was actually getting a lot of calls, and kids were actually calling about abuse, about feeling terrible, about feeling suicidal. So I think that overall things have increased. Also, children are more witness to, and I think maybe that was one of Judith's questions, that we're witness to more violence happening at home. And we know that child maltreatment is also about seeing your parents arguing, seeing adults getting into fights. And I think that's been something which is increasing. And child psychiatrists and psychologists have been actually developing methods by which they can do teleconsultations and see that the child is in a safe space to talk to them about some of these things. Because this is another challenge. It's all very easy to say do teleconsults, but if the child doesn't have an opportunity to talk, so we do things like saying, why don't you go and show me that toy outside? And when the child is outside, then we say, is anybody hurting you or harming you? So I think these are things that we are developing and we are learning in the context of this. And the last question is about social media. Definitely, I think a lot of abuse happens around social media. So necessary safeguards, and I think Zoom bombing was something which started happening a lot online, in particularly young teenage girls. And I think it's social media education probably is something really necessary now at this time when there is no other way of communication. So while social media is fantastic, great, I think educating women about how to be safe when they're using social media, how much to reveal, what kind of pictures to show. These are things which are something new, but which we need to develop. And I'm hoping some not-for-profit will start this work.
Thank you again to everyone that joined us and to all of our speakers, and big thank you to WLGH for organizing this conference and for having us today.